Good morning or afternoon or evening, depending where you are watching us today, and welcome to the Aged Care Industry Information Technology Council's research webinar, Improving Aged Care Through Consumer-Driven Health Services and Informatics Research, presented by the folk at Macquarie University. My name is Dr. George Margelis. I'm the chair of the Australian Aged Care Industry Information Technology Council and will be the master of ceremonies for today's event. Welcome to the Aged Care Industry Information Technology Council webinar, focusing on improving aged care through consumer-driven health services and informatics research. Today's webinar is part of the monthly research webinars hosted by the Aged Care Industry Information Technology Council. The Aged Care Industry Information Technology Council acknowledges the traditional owners and their custodianship of the lands on which we meet. I'm in Gadigal land, and each of us will be in different parts of the country. We pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to the country. We recognise their valuable contributions to Australia and to global society. The Aged Care Industry Information Technology Council, which I will from now on refer to as the Council to save my tongue, has been active since 2007, when it was formed by the two peak bodies, AXA and ACCA, who later became LAFA, and have recently merged to become ACPA, Aged and Community Care Providers Association. At the time, a number of us identified the need for the aged care sector to embrace technology as a key enabler to prepare for the massive demographic, social and economic changes ahead as the baby boomer generation reached maturity. The group was formed to assist the provider community to provide high quality care whilst ensuring their sustainability. It's involved bringing providers, consumers, suppliers, payers, and regulators together to design a system which supported innovation. A little bit of housekeeping for today. In terms of that, all your microphones have been muted. If you have any questions during the event, please click on the Q&A button at the bottom of your screen and enter your question into the Q&A panel. You can do that either yourself or anonymously, and we will ask the questions of the panelists going at the end of the session. Some of them may answer you in real time. This session is being recorded and will be made available to you in the next few days if you wish to share it with any of your colleagues. If you do have any technical issues during the webinar, please also use the Q&A panel to discuss that with the team, and we will work on sorting those out as quickly as possible. So, as I said, this is part of a series of research webinars which we've been running now for a few months to really drive the fact that evidence-based change in care is essential in aged care. At this stage, I'd like to introduce our speaker for today, Dr. Nasir Wabe. He's a senior research fellow at the Australian Institute of Health Innovation at Macquarie University, with a multidisciplinary background including pharmacy, epidemiology, and data science. He has expertise in the areas of outcome-based health services research, health informatics, pharmacoepidemiology, and quality use of medicine. Dr. Wabe has extensive experience in conducting data linkage and analysis of big health data obtained from primary care, hospitals, and residential aged care. I'll now hand over to Dr. Wabe. Nasir, thanks for your presentation.
Thank you for inviting me and for that great introduction, George. Thank you. Okay, so the topic of my presentation today is about improving aged care through consumer-driven health services and informatics research. What I'm going to do over the coming half an hour or so is to provide you with an overview of research conducted by our previous and existing researchers at our center, and also discuss some current projects relevant to this topic. First, I would like to start by describing the organizational charts of my institute. As you can see here, I'm from the Institute of the Australian Institute of Health Innovation. As you can see here, Professor Jeffrey Brett-Wade is our founding director, and also the director for Center for Health System, Healthcare Resilience and Implementation Science. Our center is called Center for Health System and Safety Research, or CHESA for short, and Professor Joanna Westbrook is our director. Professor Enrico Correa is director for health informatics. And recently, Macquarie University Center for Health Economy, or MOSH for short, has also joined AIHI, and is led by Professor Henry Cutler. Just to give you a context about AIHI, if you're not aware of, AIHI has over 200 researchers, visiting appointees and professional staff, and about 30 HDR students, and also manage over 80 research projects under its management, and another 16 administered elsewhere, but involving AIHI. So it's a big institute. Okay, this is our CHASER, or Center for Health System and Safety Research team. We are roughly around 45 researchers and professional staff and HDR students in the center. Okay, so this is the organizational chart for CHASER for short. And we have diagnostic informatics, which is led by Professor Andrew Giorgio. Associate Professor Rima Harrison leads healthcare engagement and workplace behavior. Associate Professor Ling Li leads health analytics and patient safety. Dr. Magda Raban leads medication safety and electronic decision support. And I'm currently looking after aged care evaluation and research, or ASA for short. Okay, so this is aged care evaluation and research team members. We are roughly around 12 people. Okay, so this is just to give you a background. Do you know that according to the Department of Health reports, about 1.5 million older Australians received aged care services in 2020, 2021, and that costed the healthcare system $23.6 billion. And the number of people admitting into aged care is increasing every year. And according to data from AIHW, there was a 36% increase in aged care admissions per year from 2011 to 2021. Sadly, the aged care clients face widespread quality and safety issues, as highlighted in the 2018 Royal Commission into Aged Care Quality and Safety report, as you might be aware of. So the goal of ASA is to generate high quality evidence through applied and translational research to improve health and service delivery outcome in the aged care sector. Our researchers apply novel quantitative and qualitative research methodologies with strong connection to consumer involvement to achieve this goal. ASA has 4 interconnected research teams. These include health services and informatics research, pharmacoepidemiology and pharmacy informatics, predictive and prescriptive analytics, and chronic disease care and healthy aging. All these research teams have a strong consumer and end users involvement. So we engage external actors in our research. So just to give you some example of health services and informatics research, we do use electronic data to generate practice and policy relevant evidence. Another examples of that is optimizing decision support tools to improve care and the user experience. For those of you who are not aware of what this pharmacoepidemiology and pharmacy informatics is, pharmacoepidemiology is the application of epidemiological methods to study medications use and effects in real life setting. In other words, it's the intersection between epidemiology and medication use. Pharmacoinformatics is a subset of health informatics, and it focuses on the intersection between information technology and medication use. Predictive and prescriptive analytics is another area. Predictive analytics focuses on forecasting future events, for example, forecasting the potential of falls, for instance, is predictive analytics. Prescriptive analytics goes one step ahead and provides recommendations based on predictions. And we have one large project currently underway on false prevention that we are applying prescriptive analytics, and I will be talking about that shortly. Chronic disease care and healthy aging is another research stream, sorry. And this focuses on understanding, monitoring, and optimizing chronic disease care and healthy aging in aged care. For instance, our team developed a health status algorithm which can be used to identify chronic conditions using electronic aged care data. Okay, so the first project I would like to talk about is dashboard of predictive analytics and decision support to drive care quality and person-centered outcome in aged care. So the goal of this project is to co-develop, implement, and evaluate a predictive analytic dashboard with embedded decision support to improve aged care. And the dashboard, this is the 5-year NHMRC partnership grant when we recently completed our 3rd year. And this dashboard focuses on falls and well-being, and the dashboard has been developed with consumers and stakeholders engagement. And in the coming year, we are hoping to do the trial of this dashboard to see the impact of it. So the partners involved in this dashboard include Anglicare, Northern Senior LHD, CNE North Health Network, Aged Care Quality and Safety Commission, and the Institute for Health Policy Research. Just to give you some context, some background information about falls in residential aged care. Falls are common and challenging issues. We are aware of that. And data shows that 1 in 3 people aged over 65 years fall every year. And among those who fall, 1 in 10 result in deaths. And it's also caused significant injury, disability, and loss of confidence. And it is economic burden is massive as well. This is our study published this year on the epidemiology of falls in residential aged care facility. The study included over 6,000 residents from 25 facilities. We found that 58% of residents fell at least once, and 45% had were recurrent fallers, meaning that they fell twice or more. And 37% experienced injurious falls, and roughly 10% experienced falls that required hospitalization. In terms of rate, for every 1,000 person day, there were 7 falls of any type, and there were roughly 3 injurious falls, and roughly 1 falls requiring hospitalization. So it's a really prevalent issue in residential aged care. So one area we're interested in this project was predicting falls risk. We know that falls prediction is complex and challenging because of the number of risk factors involved, and risk factors may change over time. For instance, medication, environmental factors, physiological and patient-related factors, or mental health diagnosis can all cause falls, and it is really complex, and the interplay is very complex. However, it can be predicted, and if it can be predicted, it can be prevented if appropriate interventions are implemented. So traditionally, false prevention has been based on false risk assessment tools, such as Peninsula Health's false risk assessment tool, which is for short PH-FRAT. It has been used widely in Australian context, for instance. However, the performance of the tool is very poor. For instance, in this study, we found that even though the tool is commonly utilized in the residential aged care setting, it showed really poor predictive performance with area under the curve of only 0.57 and sensitivity of only 34%, even though the specificity is a bit higher. So the existing false risk profiling tools have some limitations. For instance, in this study, my colleague Carla showed that only 1 in 4 studies used appropriate method, and most tools use cross-sectional data that are collected at one time point. And as a result, they can only provide static prediction, and they are unable to reflect change in risk factors over time. So that has safety implication because incorrect risk profiling means poor clinical decisions. For instance, potentially high-risk residents may miss out on receiving fall prevention interventions, so that has significant safety implications. So we believe one solution would be to utilize a dynamic fall risk prediction or monitoring tools, because dynamic fall risk prediction tools can accumulate time-varying variables, for instance, things that can change on a daily basis, and they can provide up-to-date risk prediction. So we developed this dynamic risk prediction tool, but it is not published yet. It's in draft stage. And in this tool, we utilize data from 4 different electronic databases, including medication administration, demographics data, health status data, incident reports, and 4 different data sets from 25 facilities. And we screened over 100 different variables, and we were able to identify 60 relevant variables included in the tool. And the tool showed very promising performance with area under the curve ranging from 0.67 to 0.86. And sensitivity also very promising, and specificity is also very acceptable. So this is a dynamic tool, meaning that we modeled using a dynamic predictive approach called landmarking method. And we included data from the time of admission until 60 months, which is like 5 years over time. So we tracked residents from admission to until they are 5 years in residential aged care facility. Of course, some of them made lost to follow up during this time, and the model we used accounts for that as well. So this is still in, it's not published yet, so we'll hopefully we'll publish that very soon. So the idea is then to embed that dynamic predictive tool into the dashboard and trial that in residential aged care facilities. So some of the key features and the capabilities of that dashboard was it provides up-to-date false prediction because it is a dynamic tool, and that provides real-time person-centered information, which can then be used by care staff, for instance, to act on timely manner to prevent potential falls from occurring. So it's some very promising features that can be used to prevent falls. So early next year, we hoping to trial that, and we will be doing cluster randomized control trials where 10 facilities will receive intervention and 10 other facilities will be a control, and then we will observe, we will see the outcome after 12 months, and we will be looking at health and service delivery outcomes, process measures, and economic evaluation as well. Looking forward for that trial. Okay, so the other area that I want to talk about today is about medication use in residential aged care facilities. So we know that medication management is the greatest source of complaint to the Aged Care Quality and Safety Commission, for instance. 1 in 3 issues reported to the Royal Commission in 2018 was related to poor medication use. But with the accelerated adoption of clinical information system in residential aged care facilities, there is an opportunity to focus on IT system enhancements and optimization for improving medication management. This is just some data to support how common medication problems are in residential aged care facilities. 98% of residents in residential aged care facilities use 1 or more medicines, and polypharmacy is prevalent. 84% of residents using 5 or more medications. Hyperpolypharmacy, use of 10 or more medications, is also very common at 41%. Antipsychotic use is also prevalent. And what is very important here again is the duration of use of antipsychotics. According to literatures, greater than 90 days is not recommended, but this study showed that antipsychotic use, the average antipsychotic use in residential aged care facilities is roughly 195 days, which is really problematic. Okay, so this is a funnel plot showing variation in antipsychotic use across facilities. As you can see, some facilities in red there, which shows they are prescribing or using antipsychotics higher than expected, higher than the average in this case, which is again a problematic area. Okay, so this study was conducted by my colleague Magda, a systematic review and meta-analysis to look at the temporal and regional trends in antipsychotic use in long-term aged care facilities from 29 countries. As you can see here, Australia, in the Australian data, the 12 months prevalence data is higher than other regions at 68.3. The point prevalence data is a bit lower than the UK, Ireland, and Northern Europe data, but it's still higher than many other regions, as you can see there. This is a caterpillar plot showing variation in antipsychotic use across facilities. There are substantial variations even after adjusting for relevant health conditions, as you can see. So this is also an area of improvement in those facilities. Okay, so the other project I want to talk about related to medication use in residential aged care facility is this one, transforming residential aged care through evidence-based informatics. We recently awarded MRFF to conduct this study. So the goal of this project is to improve medication use in residential aged care facility by mobilizing the power of informatics. We got 3 aims, major aims. The first one is to deliver new informatics approach to examine variations in medication use. So we will be investigating facility variation in key medication use indicators, including between and within facility variation. By that, I mean, we will be looking at if there's any variation by GPs, for instance, and also between facilities. And we will develop a prototype national atlas of medication use for key medication use indicators, for instance, things like drug burden index. We will be developing that atlas of variation as well. The second aim is to design and test clinical decision support to improve use of antipsychotic drugs or psychotropic medications and antibiotics. We will generate evidence for effectiveness of clinical decision support to drive improvement in medication management, develop an industry guide for designing, testing, and implementing evidence-based clinical decision support in residential aged care digital system. And finally, we will take an informatics approach to automating notification of medication change in residential aged care facility. So we are hoping to evaluate the feasibility and benefits to well-being by providing residents and their families with real-time electronic notification of medication change, which is going to be done for the first time, I believe, in Australian context. So in this project, we are partnering with BaseMed. BaseMed is one of the largest electronic medication management vendor in Australia. It has national coverage, covering, I believe, 6 states and territories. And they cover over 500 residential aged care facilities across Australia, over 1,500 community pharmacies, and about 3,500 general practitioners across Australia. So we are also partnering with Bupa, Southern Cross, and Consumer Health Forum of Australia, which is really exciting. This is really something that we're going to do at a very large scale kind of projects with national coverage, and very exciting about that. The other project that I want to briefly touch on is National Aged Care Medication Roundtable project. So in this project, we aiming to co-design, implement, evaluate an aged care medication roundtable underpinned by a learning health system model. This is also a 5-year NHMRC partnership grant with Anglican Baptist Cares, Calverini, and Australian Commission on Safety and Quality in Healthcare. So we almost finishing our first year of this grant. So it's going very well so far. And over the coming few years, we're hoping to design and implement and evaluate the impact of this medication roundtable. So so the vision of this roundtable is to facilitate consumer-focused improvement in the safe and qualities of medications used in aged care, with special focus on psychotropic medication and antibiotics. So as I was indicating earlier, it is guided by a learning health system approach, where we will be using data to analyze and interpret the data of the providers, and then share lived experience to the roundtable members, and then promote better resident outcomes by implementing best practice intervention, and that we believe that would support aged care partners in optimizing medication support. So it's the whole approach is guided by this learning health system approach. According to Institute of Medicine, a learning health system means a system in which science, informatics, incentives, and culture are aligned for continuous improvement and innovation. So we will be using that approach to really drive this project. The other study that I want to mention is this one, which is about measuring the prevalence of 60 health conditions in older Australians in residential aged care with electronic health record. So this study was led by Kim Lin, and she developed an aged care health status algorithm. So as we know that there are no ICD coding or standardized or unified tools to capture disease conditions in residential aged care. So Kim developed this tool to convert free text entry in electronic database, aged care database, to identifier of health conditions, if you like. So using this health macro or health status algorithm, we can identify health status of residents using this macro, which is a SAS written syntax. And it is a freely available tool, so you can contact us to if you want to use this tool, for instance, for research or for other purposes as well. Okay, lastly, I want to mention that ACER is one of the founding members of Australian Consortium for Aged Care. The goal of or ACAC for short, and the goal of this consortium is to provide evidence-based innovation to reform the aged care sector. And it is a partnership between Macquarie University, the Australian Institute of Health Innovation at Macquarie University, the Queensland University, and ROSA at Sunbury in South Australia. And also briefly mention this. This is this MRFF grant that we collaborated with. We are collaborating with ROSA at Sunbury and Queensland and several other universities. We've been awarded this large grant to develop and test the Australian Consortium for Aged Care Quality Measurement Toolbox. So this is administered by ROSA, but we're also playing some role in that project. And we believe that the toolbox is aimed to improve measurement and evaluation of the quality of care in residential aged care. And it's a very exciting project, and looking forward to have this project running. Okay, so that's it from me, and thank you for listening. Happy to answer some questions.
Thank you very much, Nasir. Thanks for a great presentation, and it's exciting to see the scope of work you guys are doing over there at Macquarie University. I do note that a lot of those research projects are looking at some of the quality indicators, which have been widely used in aged care without a lot of evidence base behind them. So quite exciting to see how building up that evidence base around things like falls and psychotic uses, and in particular, quite interested to see the plethora of chronic and acute diseases prevalent in our aged care facilities. Because one of the things I've seen over my period working in aged care is that shift of acuity from in residential aged care from independent living to essentially very high level care. A couple of questions start to pop up. First question from Alan Nugent. Can you tell us what were the most useful features in your fall prediction model? So were there any particular features that stood out as having the highest predictive value?
Thank you very much. That's a great question. So I tried to mention some of the key features there. The fact that it has real-time information. So we're using real-time medication use information, real-time incident reports, and whatever happens, whatever is captured in that electronic system, we using that information if it's relevant to false incident. For instance, we are capturing false risk increasing drugs, like FRIDs for short. So those are medications like antipsychotic, antidepressant, sedative, hypnotics medications. So if there's any recent change in those medication prescribing, we can immediately flag that, and that will be communicated to care staff, and they can take necessary measures to prevent falls from occurring. So that is one of the key and I believe unique feature of the dashboard. It is predictive of what's happening, but it's also prescriptive in a way that so once we identify that there is a potential risk of falls, we are including recommendations. We are including what to do, what staff members, care staff can do to prevent falls from occurring. So that is a powerful thing, I believe.
Okay, so following on from that question, when we look at things like the star rating systems, for example, some of the quality indicators have become part of that measurements in star ratings. But one of the big challenges we face with using those sort of metrics in something like star ratings is risk rating. So again, someone who's more likely to fall, who has a higher probability of fall based on your tool, will still influence the star ratings results. Is there any work being done looking at how you can give a more accurate comparison across risk ratings of falls as an indicator of quality? So, for example, those who are at high risk of fall are a different indicator than those who are at low risk of fall and still fall. So, is there any way of using your tool to normalize that risk rating across a heterogeneous group of at-risk individuals?
That's a great question, George. Thank you. So I'm not 100% sure if that can be done, but because star rating has not been implemented yet, I believe. Mm-hmm. But there's a possibility to utilize. So false is one aspect. It's just one of the quality indicators. There are other quality indicators, of course, like medication use, pressure injury, and several other quality indicators. And I think recently they added more indicators as well. So definitely there is a way of doing that. Once the star rating is implemented, there is a way of informing that. The false work can inform that, but it's just one part of it. There need to be other consideration as well, I believe.
Absolutely, yeah. It's just interesting because as we look at personalized medicine in things like oncology and infectious diseases, I mean, I think we also need to shift our focus to personalized aged care as well, and that services need to be fine-tuned for individuals, and that's the sort of information that you guys are capturing, I think, is critical to that. Anyway, as further questions, a few more questions popping up. Looking at the work around psychotic drug use. So again, that becomes an interesting challenge. So we obviously can measure the usage. Correlation between diagnostic codes and their usage, was that part of the work being done as well? So were there specific diagnoses that were triggering the use of antipsychotic drugs, and were they necessarily related to psychiatric issues, or were they more? So I guess what question is the evidence that they're being used more for sedation rather than active clinical use? Any comments on that?
Yeah, I mean, that's a really great question. So one of the challenging thing in aged care electronic data, because we rely mostly on existing electronic routinely collected data, is, like I was mentioning earlier, it's about the lack of standardized, unified diagnostic codes in aged care. So we're relying on text field entries and looking at that text field, whether the patient, let's say, has diagnosis of dementia or not, and trying to figure out whether psychotropic medications are appropriate or not. So we're looking at from that angle. So the first challenge is to identify what kind of diagnosis that resident has. So the next step after that, especially the medication safety stream, which is led by Dr. Magda, is looking at the appropriateness of psychotropic medication use in relation to this diagnosis, whether they got dementia or not, whether they got some mental health diagnosis, other mental health diagnosis, and what guidelines says about that. So we are doing a lot of work around that. And also in the new project that we just starting, we will be hoping to explore those issues further and see if we can use informatics approach to address those issues in more details.
Okay, we're getting two threads of questions from providers. One about how do we keep up to date with the work that you're doing, because obviously it's very important. So I'm assuming you guys have a rolling cycle of presentations and that. We will constantly invite Macquarie University to our research webinars, as we have for many years. But do you have a program where people can register online to get updates on your programs and get better understanding what your work you're doing?
That's a really great question. So one way of doing that we're doing is through that Roundtable project regarding the medication. That is one very nice avenue. And another thing we recently started, actually, I don't know, George, if you heard about that, about the health series, health innovation series. So Joanna and Magda recently started that. So that is a great avenue to get update about what's happening in medication use, residential aged care setting as well. So yeah, so Roundtable and health series, and anyone can sign up for that health innovation series, which is important.
And I've been fortunate. I've been attending those seminars back in the good old days when they were in person, and over the last couple of years virtually. And I think we're actually starting to have a few more in person coming up. I noticed we had Blackford Middleton over there last year, so in person. So yeah, highly recommend everyone go to the AIHA website, register for to be updated. They do send out a regular email newsletter, and like I said, there are a number of groups there. And whilst there's an aged care specific groups, many of the other groups have a lot of crossover into the work we do as well. The other question we're sort of getting is how can they be involved in these projects? So how can aged care providers put their hands up to collaborate with you guys, provide possible sites to work with? Is there an active process there, or is it just a reach out and have a discussion and work out how the best way to work together is?
Yeah, that's a very important thing again. So most of the time we contacted by like if they see a newsletter about a project or something, they contact mostly our director or our team members, and then we start initiating, we initiate conversation with them if we can do, let's say, NHMRC type grant with them. But in this Roundtable project, this National Medication Roundtable project, even though we started with 3 providers, Anglicare, Baptist Care, and the Scalabrini, we're hoping to expand our reach, and we're happy to for anyone to be involved moving forward. Not now, but maybe starting from next year, we're hoping to expand and include more providers in that. But generally speaking, when we want to do a project, mostly we contacted by external people through different means of media, social media, or newsletter, or things like that.
Sure. Well, I'd like to add the council as a venue, avenue for that as well. So if people are interested in working with Macquarie University and need help in contacting them, please feel free to contact us at the council. We have a very strong relationship over the years with them, and it's been working well. Obviously, the pharmacy part of it's a big part of it. I mean, probably it may reflect your background, but we know that polypharmacy is a huge issue in aged care, both for the fact that the associated morbidity and mortality associated with it, but also just the complexity of managing such multiple medications. Does your work include looking at tools to improve that medical both the adherence, but also the cognitive process of removing medications, which I found is honestly one of the hardest things in aged care, is that once someone's started on a medication, very few clinicians are willing to sort of stop medications, but we've seen significant effects when that happens. Is that part of your research, looking at both the problem of polypharmacy, but the solution? How do we actively reduce the number of medications in a safe and effective way?
Yeah, that is really very important point, George. Especially like things like deep prescribing is very challenging. We know that there is a medication use issue in residential aged care facilities, and deep prescribing has been a big thing. And I'm aware of different research in deep prescribing in Victoria and South Australia as well. What we're hoping to do, we haven't done a lot on deep prescribing or ways of reducing inappropriate medication so far. But in this roundtable project, what we're hoping to do is to conduct nudge intervention. This is a new approach of actually providing data to prescribers. In this case, let's say if their antibiotics are inappropriately used, or psychotropic medications are inappropriately used, we will be providing them with data, comparing them to different facilities. Your colleague, let's say this facility is prescribing too much antipsychotropic medications compared to similar other facilities. So if we present them with that kind of data, the prescribers may ask themselves, why I'm doing this, why this facility is doing more prescribing compared to similar other facilities. And they, instead of giving them hard rules to de-prescribe, maybe providing them data and letting them question themselves is a sort of like a nudge kind of intervention. In other disciplines, that kind of intervention worked. So we hope this can also kind of work in this setting as well. So we're hoping to try that in the coming years in the Medication Roundtable project.
Excellent. Fantastic. Well, I mean, the other thing, of course, is Macquarie is quite famous for its health track studies, where it's looked at the compliance to guidelines by providers as well. So that we're looking to do similar studies in aged care as well. So again, the evidence base is probably not quite as strong as it is in acute medicine, but again, what percentage of users of providers are using evidence-based guidelines, and which ones aren't?
Yeah, so that project, for instance, the care track work conducted by Professor Jeffrey Braithwaite's team, is actively doing that kind of work, which is really a great source of information.
Fantastic.
Yeah.
Well, look, we're starting to run short of time, so thank you very much for your presentation. I think there's a lot of interesting information there. Are you happy with us to share the slides with the attendees?
Yes, sure.
Because there's a lot of information there they want to be able to share with their colleagues.
Yes, please feel free to share the slides.
Appreciate it. Thank you very much, Nasir. So, on behalf of the council, I'd like to thank you for your presentation. We look forward to ongoing engagement. Like I say, right now we're involved in some of your projects as well as co-facilitators, and like I said, the council's more than keen to support the projects going forward. So we look forward to working further with you.
Thank you very much. Thank you. We really appreciate your invitation, and we're looking forward to continued collaboration with you. Thank you very much.
Thanks a lot. So as we get ready to wrap up, so it's been a very informative session. Just letting you know a couple of extra things coming up in the near future. On the 29th of November, if you're an aged care software or service provider vendor, we are running a forum to discuss the issues around aged care vendors on the 29th of November. You can register through our site. Again, we're focusing on how we can collaborate better with vendors going forward to work together on a collaborative solution going forward. We all know there are some major issues facing aged care and the use of technology. We did see in the last budget just a couple of weeks ago an announcement around a significant investment in technology for aged care. We want to make sure that investment is properly utilized to maximum effect. And we believe collaboration between government, vendors and providers and consumers is critical for us to do so. And as pointed out in these great presentations we've been running through our research webinars, making sure the academics are across those projects to make sure that they are evidence-based, and if the benefits coming out of them are captured so we can go forward. So 29th of November, for anyone involved in delivering technology solutions to the aged care sector, please join us for the aged care vendor. Our next research webinar is being run by the University of Melbourne on the 8th of December. Again, you can register for that on site at the Aged Care Industry Information Technology Council website, aciitc.com.au. We look forward to that. And then we are giving you a little bit of a break over Christmas, New Year, and I'm hopefully the team and I at the council had a bit of a break, but we will be back on the 31st of January with the Flinders University Research Webinar. And again, details will be forthcoming on our website. Do note there are also a couple of other functions happening. So anyone in Sydney, the Australasian Institute of Digital Health is running a forum next Thursday, I think it is. Yeah, on the 15th. I'm looking into aged care. So if you go to the digitalhealth.org.au website, you'll be able to find that out. And there'll be a lot of work going forward. And we are looking forward to an active 2023 now that things are starting to settle down, and we'll be announcing details around ITAC and other events going forward. So our contact details are on your screen. I'm available through Chair, and Livingston, our Executive Officer, through Executive, and Georgie Gould, who does all the hard work behind the scenes to make us look like we know what we're doing here. Thank you very much to Georgie for her great work. She's available through Secretariat. Keep an eye on our website. Feel free to make contact with us. Join our LinkedIn group. Our LinkedIn group is growing. We're now over 600 people, and trying to get some active discussion happening there around what we can do going forward. Like I said, big trigger, $380 million released for aged care technology in the last budget. I think it's essential that we as the industry play an active role in ensuring those funds are properly utilized to improve quality, safety, efficiency, and effectiveness of our solutions as we provide care to older Australians, but also to help drive some local innovation and commercial development so that we can have a sustainable sector, both in the vendor, but also in the provider market here. So on that note, I'd like to say thank you to all our attendees. Thank you to our presenters, and we will look forward to seeing you at our next webinar. But in the meantime, join our LinkedIn group, get active and involved in the discussion. If you see any interesting articles you believe are worth sharing with the rest of the community, our LinkedIn group is the best way to go. Thank you, everyone. All the best.